Now, going a different direction, one of the questions has to do with psychological and behavioral therapies. Which of those is the most effective in fibro and also for chronic fatigue? You know, is it relaxation and stretching? Is it cognitive changes? Is it meditation? What's the most effective and why?
I think the research is at such an early stage that there's considerable confusion here. You've heard from panelists about the education of the patient with regards to various aspects, and because cognitive behavioral therapy has that educational component, it was recognized as perhaps being the approach that psychology has to offer that would be most useful. About 2/3 of practicing psychologists identify as being cognitive behaviorally oriented, and so we've got a factor here that has also influenced psychology's response. But I've had several patients who have been through a CBT program and found some benefit, but not significant benefit. And when I have the luxury of working with them for a longer period of time, I find out, first of all, that there's a childhood trauma that has never been recognized or addressed. There's the AAA type A behavior that a 10-week program didn't put a dent in, that there's grief or other losses that haven't been addressed. And so I think clinically, as I talk to colleagues, that the psychodynamic approach has a role that will be increasingly recognized. Having said that, I think that if as a physician you're referring and you've got one bullet in your gun, that some kind of mindfulness relaxation program would be the place to start, because you're looking at autonomic arousal in both of these illnesses, trying to bring down that sympathetic elevation, and oftentimes just developing some awareness in the patient so that they can become better self-monitors in terms of their symptoms, their responses to medication, and that might be the place to start. But I think that we're going to see CBT become less of a standard. I think we're going to be looking at a broader psychological approach, and I think we're going to see an increasing appreciation for awareness training techniques.
Any other comments about that particular issue? My own experience, oh, yes.
Institute for Heart Math is a nonprofit organization. Dr. Childre can teach people how to do autonomic self-regulation. I find it's very helpful for people who have that problem, the autonomic dysfunction. So Institute for Heart Math, and also John Kabat Zinn and the meditation mindfulness approach can be very helpful for a lot of these people.
So the suggestion was made, the Institute for Heart Math, which you can get online and so on, it helps with some of this experiential change, and some of the John Kabat-Zinn mindfulness stress reduction programs, which are now, is one of the big things in the American Psychosomatic Society for study, is implementing this manual. It's available from University of Massachusetts. His program based on mindfulness meditation is now being studied very aggressively compared to CBT. My own experience in referring patients for all of this is that the usual talk therapy isn't as effective as experiential therapies, where they can really get the body into it with relaxation, visualization, and so on. And most therapists, most psychotherapists, as Dr. Drescher mentioned, are kind of more talk therapy oriented. So you want to get somebody who kind of has this experiential orientation, I think, for the kind of patients that I've seen.
I guess I would also add that when I think of my fibro and CFS patients, and if somebody were to ask me a simplistic question like, what are you trying to do with them, that my first response would be, I'm trying to increase their capacity of awareness. And that as that increases, then they're better able to pace themselves, which is a big piece with the CFS, but also with the fibro, and to be able to recognize how variations in their behavioral patterns during the day exacerbate symptoms, and that people can become much better self-managers as their capacity for awareness increases. And that's not something that is typically been the focus of cognitive behavioral techniques, but is very much involved with the self-regulation approach.
Yeah. There's a question that was written down. What about opiates? And SOMA, of course, it's recently been scheduled, and then other muscle relaxants, most of which are not scheduled. And then I have a kind of another question that I think kind of travels the same vein. It says, do you advocate treating ADHD symptoms, fibrofog, and if so, with what medication? So I think what we're faced with, there are two issues. One is a philosophical issue, which is very personal for the prescriber and their medical legal liability. And the other one is the issue of physiology, and there's, I think, a collision zone between those two. Physiologically, there's reason to believe that a bunch of fibromyalgia patients make a bunch of endorphin, and why would you give them more? And I think there's validity in that, and so I think as a prescriber, if you are inclined to write a trial of an opioid agonist, determine whether or not there's any pain relief. For those people who have a radiculopathy or a cervical cord compression on MRI, I tend to be a little bit more liberal, pending surgical evaluation. If ultimately they're not surgical candidates and they're benefiting from an opioid, I don't have room in my, I'm trying not to make room in my practice for opioid maintenance. Now I have that luxury. I'm a consulting physician. I'm no longer working in primary care. But those of you in primary care, do cultivate your relationships with your anesthesiology colleagues who are doing outpatient opioid management. The other problem that I think we're faced when it comes to the idea of Schedule II medications, do I want to be responsible? Obviously, there's a medico-legal burden. Are you doing urine drug screening? Are you evaluating your patient's psychological comorbidities? I think that there's a high demand among borderline personality and bipolar patients for opiates. And there's various reasons, both physiologically and personality-driven, why that might be the case. There was an editorial that came out that suggested there may be a variant they called pseudofibromyalgia that was the bipolar patient demanding opioids. The problem, I think, physiologically, and this gets to the ADHD question, do I treat ADHD with scheduled medications? And the answer is a robust yes. I try and do it with phentermine, which is a triple reuptake inhibitor. It's not scheduled. Depending on the state you're in, there's various levels of controls on whether or not you can prescribe it. It's easy to get it prescribed if you have paid for if you have a BMI over 32. Drugstore.com was a readily available source of that. They relocated their warehouse to Ohio, and now it's a very complicated thing. They'll only provide it for 3 months at a time. So the collision with physiology is here you have a system where the opiates and the amphetamines work that's broken. And nobody has a problem treating asthma with beta agonists or hyperlipidemia with statins because those aren't being abused. That's a system that's broken. You use a drug. Here you have a system that's broken, the mesolimbic dopamine system. There's ample evidence that it's broken. How do you modulate it? With class 2 stimulants and amphetamines and opioids. And so then and then again we have this philosophical burden. We don't want to write those. So then the patient is caught in the crossfire, and that's just an unfortunate reality. So
I might comment on that as well. Many people with fibromyalgia have another pain generator. They may have a back injury, or they may have arthritis that is now being amplified by the fibromyalgia. 1/4 nearly of rheumatoid arthritis patients have fibromyalgia. So you may have to treat the peripheral pain generator, and opiates and NSAIDs may help for that. They don't seem, in controlled studies, there are very few of them, but in controlled studies of opiates for fibromyalgia itself, they don't seem to work very well. And if you use them around the clock, you may even increase the sensitization, the amplification. In my experience, an opiate may well work for a bad day, short-acting opiate for a bad day, but the problem is they've got pain all the time, and so they don't just use them on a bad day. They start using them around the clock. And I think it's more counterproductive to put them on opiates than helpful, unless they've got some other reason to use the opiate. Oh, we're about down to the end. Let me just toss out two more questions. People with fibromyalgia, there's a genetic component to this, obviously. People who are asymptomatic, who are primary relatives, sibs and parents, have a very high incidence of tender points, even though they don't have the disease. How can you prevent them from getting the fibromyalgia? How do you, in a prone family, how do you prevent it from developing? So, okay, yeah.
I said good mental health, good sleep, and fitness, exercise would be my advice. And lack of mechanical trauma. Seatbelts.
Well, I think it's really kind of an important issue. Be sure that people in the family really give attention to sleep, they get regular exercise, and there are ways to learn to be stress resilient. Group programs that teach some of these experiential things, and I think it's very useful preventively to do that. The final question had to do with prognosis. Are people with fibro and chronic fatigue bound to have this the rest of their life or not? Do they go into remission? And who is it? How do you get more remission for prognosis than just put up with it? Thoughts?
Certainly some patients who have post-viral fatigue, there's an increasing percentage of people who get better. We have limited data, and we have a few prospective studies. We've looked at EBV in adolescents, and the majority of people recover from cases of post-viral fatigue, and there's a percent that the longer they go, probably the less likely they are to recover. But this is such a heterogeneous group of patients that we're talking about that I don't think that question is answerable. I think some people can improve tremendously, and there are other people who probably are going to be ill chronically, and everything in between.
Go ahead.
But I think that point about early detection is really key. Most of the studies have shown that the earlier someone is diagnosed and the earlier treatment or various interventions begin, the more likely you will recover. Perhaps not fully, but in that graph, remember that graph that I showed, there is the chance for improved health.
I'd like to emphasize that in spades for fibromyalgia. Early's the name of the game. The longer it goes, you start seeing these structural changes in the nervous system that sort of hardwires it in. But within the very first few months, if you treat aggressively fibromyalgia, you can get remissions. And they can do well, and then you can prevent it with these non-pharmacological things. Here's how you get it early. If a person comes in with more than one pain problem, let's say headaches and back pain, the odds for this amplification problem are 6 to 8 times normal. So if they come in with more than one pain problem, ask about the other pain problems. You also get a little neck pain, you get a little muscle aches. Push on the tender spot, see how amplified this nervous system is. Ask about those comorbidities. Do they get migraines and anxiety? And that's where you get it early. And it's very treatable in that early stage. I think that's a really important issue, and particularly at a primary care issue.